wanted to take this time to welcome everyone to the call. And now I'm going to turn it over to Jesus Gaeta from our team for a quick poll that we're all going to participate in. So we'll give you a moment to reorient yourself towards the screen and be ready on your keyboard because you're going to have several questions pop up. Jesus, take it away.
Hi everyone, good morning. Welcome here from the San Francisco DPH team. So we're gonna get some information and see how people are doing now before we get into the details of what our presenters have to share.
Jesus, apologies for some reason. I'm having difficulty with the polling. It may be because someone else on our team is also signed in as a host. So I'm going to ask everyone on our team to please, on the San Francisco team, to please check the polling tab at the bottom. If we can't resolve this very quickly, we can definitely do this as a chat waterfall in the chat box. So everyone may want to just pop open your chat box. Just to be sure that you are ready. Oh, Brian, I need you to give me back hosting, please.
Oh, sorry, I reclaimed it and gave it to Jesus.
Oh.
But I can do it and give it back to you.
Bye-bye, host. It was fun while it lasted.
Okay, we're still having some difficulties, so apologies. So Jesus, do you have the questions, or do you want me to read them out?
Yeah, so I don't have the questions actually, but.
Okay, so I can read them out. So our first question is, so if everyone could type in their response in the chat box, has your organization ever implemented or utilized telemedicine for any efforts? So whether it's HIV related or not, has your organization utilized telemedicine for any efforts? So please go ahead and just type a yes, no, or unsure in the chat box.
So we are getting a ton of yeses, affirmations. It looks like a lot of different organizations and jurisdictions have already implemented telemedicine.
Great, and we can pop on to our second question because this will take a moment of thinking for folks. What, if you would like to implement telemedicine or you have implemented telemedicine, what types of challenges do you anticipate or have you experienced? So there's an opportunity to talk about any challenges you've experienced if you already do telemedicine, or challenges you anticipate if you'd like to do telemedicine.
So for this question, Bev Wasserman says costs. Lyle says technology. Preston says technology with various locations and clients. Leslie mentions willingness and internet access. Becca is mentioning workflows. D. Anderson is saying provider resistance. John Murphy, lab requirements. We should save this chat and keep note of these.
Absolutely. And feel free to keep populating those even as we move on to our next question, because those responses are extremely valuable. Our final question is, if, and this is only for health department staff that are on the call, so only health department staff. If you're not a health department, you can take a break from the keyboard. So the final question is, would you like customized technical assistance on telemedicine for your health department? Yes, no, or unsure?
So Lyle from the state of Nevada says yes. Sabra says yes. John Murphy, maybe, unsure. Preston, yes. Becca, yes. G, possible. Well, after we provide some TA to other jurisdictions, hopefully we'll sell it to the people that are unsure.
Great. And hopefully as you learn more today within our learning community, it'll help clarify where you might be going with telemedicine. So at this point, it's my privilege to turn it over to my fellow SEBA manager from the Denver Prevention Training Center, that is Mr. Ty Edward Few, to introduce our first presenter on the call.
And I'm happy to do that. However, I do know that Anshay wanted to make a quick announcement about some upcoming town halls. So Anshay, do you want to share your announcement?
Oh, yeah. I was going to wait to the announcement part, but I just letting folks know, if you are part of or funded under 1906 and receive EHE dollars from CDC and are EHE county within your respective state health department jurisdictions, we're asking you to participate in our next week West Region EHE Town Hall that is happening on November 19th, which is a Thursday, from 3 p.m. to 5 p.m. The counties that are EHE counties: Arizona, Maricopa County, Washington, King County. We have Nevada, Clark County, and then we have the 8 EHE counties in California. Of course, that is Alameda, San Bernardino, San Diego, Riverside, LA, San Francisco, and I believe I'm leaving out 2 more, Sacramento, and there's 1 more, but please forgive me. But if you are within those EHE counties, we're inviting you to that. There'll be more info shared within group site. So are those who are respective EHE county, that is for you to attend. Thank you.
All right. So good day, everyone. We are so happy that you could be here for this particular learning collaborative. You know, the purpose of these is to really promote peer-to-peer learning and for you, state health departments, to get a chance to hear from some of the experts in the field. Well, it is my pleasure and my opportunity to introduce my friend, Dr. Karen Wendell. She is the director of our HIV STD Prevention Training Center. Dr. Wendell did her training at Johns Hopkins in the ID. She is well known within the field, and she's just really great to talk to about telemedicine. She has great ideas, and she makes what seems complicated to me, she makes it accessible and easy to understand. I will steal 30 seconds of her thunder and say during her presentation, we can share with you a PDF that we developed in our STD regional PTC on telehealth, and it has a lovely insert that provides an overview of all the telehealth platforms. And we can put that in the chat and you can download that. And that can be one of the things you can do to build your capacity for TA. Oh, Karen put it in the chat.
It's crazy out there.
Oh, it is crazy out there. But if we could ask you to mute yourself if you are not talking, that would be great. Additionally, this is your time to learn from one of the best. And after we finish, you'll be able to ask questions. So I turn it over to my friend, Dr. Karen Wendell.
So thanks so much, Ty, and thank you for inviting me to come speak. I wanted to start out by asking everybody to enter into the chat if the programs that you're involved with are engaged in providing STI services, and just a quick yes if you're doing that, or no, or I'm not sure.
No.
Just to get a feel for, and it looks like a lot of yeses coming in, so that's great. And so the link that we shared is really designed, I'll say, out of our own kind of pooled thinking about what to do when COVID hit, and thinking about how we provide STI services in our sexual health clinic, but also in our infectious disease clinic that's in our public health infrastructure. And so we're all in the same building and thinking about how we do that. And, you know, noticing how many of you commented on, you know, things that were challenging about telehealth. I think workflows for us have definitely been something that we've found to be a challenge. And then just figuring out like who is appropriate for telehealth. Like, should this person actually be in a telehealth visit or should they be in person? And I think it becomes so stressful, especially when numbers start going up, making sure that you're providing quality care. And there are patients that obviously do not belong in a telehealth environment. And so the link that we shared is to a document that we created to really think about how can we safely provide STI care. And so I think the document really just helps us both in our clinic that provides care primarily for persons living with HIV and in our sexual health clinic, thinking about if we're triaging people properly. And really in talking about just moving into telehealth, how do we select the right people? And when in a telehealth visit do we decide this isn't the right venue? And I think some of those concerns actually depend very much on where you are with the epidemic and the degree of how shut down your community is. And I say this now because I don't know how many of you, and I'm interested if people could enter that in the chat, because that was super helpful. Thank you for doing that. How many of you are currently going into a higher phase of shutdown in the communities that you're serving right now and needing to transition care again? Because we are doing that right now in Denver. So our rates are going through the roof, our hospitals filling up, and we're once again sort of going from providing more in-person care to closing down somewhat. And so when we put together this really just informational guidance, it was to look at if you're providing STI care to folks and you're not doing screening, you're trying to provide care for people who actually have symptoms, what's appropriate to do? And our first thoughts around this, and I'd be interested to hear other people who have been struggling with these issues in their clinics. Our first issue was what's reasonable to do as telehealth, what's safe, how can we ask the right questions very quickly to determine who needs to be converted into an in-clinic visit. And when we do that conversion, how do we make sure we have all the right pieces together to minimize our use of PPE and to also maximize the protection of the staff as well as the client. And so that was sort of our first swipe at it, and really in looking at STIs, decided that we really wanted to guide folks to looking at gauging the risk to the patient of not coming in and having a physical exam. And so looking at what symptoms that they're having could be indications of more high morbidity problems that would have sequela for the patient. Things like pelvic inflammatory disease, epididymitis, syphilis, especially in the pregnant patient, signs of disseminated gonococcal infection, or symptoms that could be suggestive of neurosyphilis that really demand emergent evaluation. And then really the CDC came out with guidelines, I think it was around April, that we incorporated into this document that really go towards those other people that have like cervicitis, urethritis, even genital ulcer disease. Can we treat them syndromically based on what they tell us? And using video, you can also do a limited type of visual clinical exam. Can we develop protocols for how to treat those individuals? And so those came out and we did implement them. And I think they went well, but as you all have alluded to, we not only converted sort of our STI visits, but our PrEP visits. And so some of those, of course, are going to entail evaluating folks for STIs, but some of those folks really do need labs. And so your telehealth visit, you might feel went terrifically, and you feel like you're providing, what you needed to provide and didn't really need to do a full clinical exam. And you can treat empirically, syndromically, but some folks really do need that adjuvant of the lab. And how do you do that? And so in this document, we kind of go over some of the things that we thought through and some of the options that we have. With those, including things like a quick lab visit where you're in and out, you collect your samples, you leave again, and it's scheduled. And so you have a very brief interaction with staff. You're not sitting in the waiting room for extended periods of time and you leave. Some programs have successfully incorporated home testing. And how can you do that? So we give some resources on how you can kind of partner with commercial labs. I think it's very rare that public health labs and even private labs have validated for home collection, and it's important to realize that does require an additional validation. So we can't, unfortunately, take a kit that's self-collected, give it to a patient, let them do it at home and mail it back to us. You have to validate that first in the lab. And so what are our options to do that? Couple it with a telehealth visit. And we give some suggestions on that. And then finally, just doing those quick self-collected in the clinic drop-off type of samples to alleviate the lab collection. In addition, I think we can really leverage some point of care tests, because for us, some patients are really just needing another HIV test to continue their PrEP. And could we use a test like the INSTI and have a very short interaction with the patient, do a quick finger stick, and have a result back within a minute? And then finally, talking about how we treat the patient. So if you decide that syndromic management is indicated from a telehealth standpoint, how do you go about getting them treatment? In our clinic, we tried a couple different things and they've been working fairly well. We can mail treatments. If it's something like chlamydia, we can have a pharmacy mail it to them. They can go to their closest pharmacy. And even for things like depot, we've been doing things like meeting them in the parking lot and giving them a shot of depot. So it depends on the medication that you're talking about, certainly, because some of them we really recommend that there is a monitoring period like bicillin, where you're giving them a penicillin, they could have a reaction. And some of them we can give orally or we can give in a drive-by fashion. So we're doing a lot of drive-by. So folks that we diagnose with chlamydia through a stop-in lab test then can either go to a pharmacy, or if they're coming to us and don't have insurance, we have our public health supply and can have them drive by. They tell us, they call us when they're out in the parking lot, and we walk it out to them in a little brown paper bag, have them confirm their ID quickly, and then we give them the medications and the instructions. And so we can do many things to really make telehealth work and couple it when necessary with in-clinic, in-lab, or drive-by services if we don't have the luxury of using those fully at-home, mail-in type of processes. So finally, in our document, we also include some tools that can be used to get those video visits done. And I do think there are so many obstacles to doing video visits with technology, with confidentiality, and even with the software that we use with our EHRs. And realizing that phone visits work very well. There are many things that you can't do without the video visit, but there's a whole range of things that we can do with limited technology. And so with that, I would also say that we have gone to expanding things like EPT. So expedited partner therapy, the CDC guidelines are currently for using those only in folks that are men having sex with women, or cis women having sex with cis men, diagnosed with gonorrhea or chlamydia. We have really expanded the use of expedited partner therapy for gonorrhea and chlamydia to all populations, to assure that people can be kept as safe as possible and not have to interact with clinical care in an unnecessary fashion when rates are really high of COVID. So I want to leave it to there and ask for any questions that would come in, and then potentially hand it off to my colleague.
Karen, there was one question in the chat. There was a question from our friend Patrick Piper. Can you say more about those who may not be appropriate for telehealth services? What does that look like?
Yeah, so I'm going to actually go ahead and share screen. And I'm going to ask Ty to tell me if you can see this.
I can see it.
Okay, so this is the document that I was referring to. I'm gonna, let's see here, I need to move this. Okay. So when we talk about our general principles of who can get safe care, I'm gonna scroll down a little bit more. The people who we'd say absolutely, we would not recommend managing over the phone are people that could have complicated STIs. So thanks for that question, Patrick. I think it does deserve some more attention. So when we're screening these people over the phone, we do a two-part screen, right? One is Are you having COVID symptoms? Have you been exposed to a person with COVID? Because if we have to bring them in, we want to bring them in the right way. And then the reasons to bring them in would be things like testicular pain and tenderness, fevers and chills, rash. I think the one thing that's missing from our list here is symptoms that we might think are compatible with acute HIV. And those are really tough because those can overlap with our COVID symptoms. So for PID, asking women about abdominal pelvic pain, dyspareunia, abnormal bleeding, with or without fever, nausea, or vomiting, and disseminated GC. So if we have patients calling in about rectal discharge, a sore throat, penile discharge, we may be able to treat them, especially for the urethral discharge and the rectal discharge, you may be able to treat them syndromically over the phone. But if they have accompanying fever or new joint pain or tenderness, we need to be considering disseminated gonococcal infection because that does occur, and we wouldn't want to undertreat someone and not recognize more serious disease. Similarly, syphilis and pregnancy. So when we talk about potential syndromic treatment, especially for genital ulcer disease, we can use doxycycline and we can defer or obtain a lab visit only to get more data. But in pregnant women, we really have to use injectable penicillin. We have to use long-acting bicillin. And so we need to bring those women in. And we need to know if they have syphilis infection because the risks are just so high in syphilis and pregnancy. And then finally, neurosyphilis, obviously, typically something we have to admit to the hospital and has, really severe complications. And so we need to diagnose these as rapidly as we can. And so anytime we're thinking about syphilis in a patient, we're going to have to do screening for neurologic involvement. So vision, photophobia, ocular pain, hearing loss, tinnitus. Anybody who's complaining of these things needs to be brought in and may even just need to go straight to urgent care. But when we identify one of these symptoms, like I said, if we have suggestions of more complicated disease, we are obligated to do a full evaluation and bring them into clinic. But then we want to know if we have to bring them into a room that is an isolation room and use full PPE, so have on our N95 mask and our face shield and our gown to take care of this patient, or whether they can be managed in a standard fashion in our clinic, which includes droplet masks as well as face shields, and of course, standard precautions with gloves. And normal flow through our clinic. So patients who have symptoms of COVID or have been exposed to COVID but need to be seen don't sit in the waiting room. They don't go to phlebotomy. They don't sit in a triage room or in the regular room to get their initial vitals done. They go straight back to an isolation room and we do everything in that one room.
Thank you. That's very helpful.
So that information is on page 3 of the manual that Karen put into the chat. On page 11 of that same manual is a lovely glossy chart that reviews the pros and cons of different telehealth platforms. Dr. Wendell, we thank you so much for joining us. We're going to transition to Dr. Jeff Hart-Cooper, and if you have additional questions, we can ask those questions towards the end.
Great, thank you, Ty. And I'm privileged to introduce at this time Dr. Jeffrey Hart-Cooper from Stanford University, and who's running a tele-prep program for young people across California. And he'll go into some detail about that and talk to us about the implementation and some of the lessons learned from it. But I also wanted to sneakily add in that Jeff is also one of our expert capacity building assistance consultants around this topic, and is available for some time for folks who are looking for some technical assistance around this issue, especially with reaching young people. So make sure to contact us about this. Or Denver, if you're interested more in hearing some of the work that Karen has done, or any of our SEBA partners in the West. So without further ado, I'm going to turn it over to Jeff if he wants to say a few more words to introduce himself while I get his slides up.
Great. Thanks for the introduction, Gary. So a little bit about my background. So I'm a pediatrician almost full time. And so I have a lot of experience with working with adolescents and young adults. And then have, some background in terms of like sexual health, HIV prevention. And I think that what I wanted to talk about is kind of specifically like youth considerations around PrEP. And I think this is a really nice addition to what Karen was saying. And the other thing that I would add too is that at least clinically, we're doing a lot of telemedicine. And so even in my like clinical day-to-day, I also am happy to share kind of experiences that we've had kind of through Stanford in terms of, when do we bring these patients in? When do we see them just through virtual visits? And when we bring them in, kind of like, what's the safest place to do it? And at least for our model, what we've done is we've kind of had our clinics, our primary care clinics that don't see anything that could be COVID related. And then we have these kind of centralized respiratory clinics. And that's similar to kind of what Karen was talking about in terms of like, how do you use your local urgent cares as well? So I'm just going to launch into it. If questions come up during the chat, I'll try to keep an eye on them. And certainly maybe if Gary and Ty could just let me know. But yeah, I think that our overview really is going to focus more on the youth perspective for teleprep. And this program, actually, we started before COVID hit. And it's been a really interesting way to kind of see how this sudden evolution towards telemedicine has really catalyzed a lot of these telesolutions that we can use to help reduce some of these barriers. Next slide, please. All right, oops, let me switch this. Cool. So our mission is just to improve the access to quality PrEP care for adolescents and young adults in California. So we started just within our Stanford network, and now we've recently opened to patients outside of our network. But this is a pretty lofty goal, but it's something that we've set up our system to be able to scale and accommodate as we grow. So to take one step back, I think that youth are special, right? So the way that you're going to approach a 16-year-old about sexual health and PrEP is going to be very different from how you approach an adult. And so I just wanted to take one step back to just review adolescent cognitive development. Some of you may have teenagers, some of you may have recently been a teenager, but this is just a good way to kind of just frame how we're thinking about it. So I think as a pediatrician, I think of it as, early, middle, and then late adolescence. And obviously you have, some 18-year-olds that are more, that have the maturity of a 14-year-old, and you have some 18-year-olds that have the maturity of a 25-year-old, but this is just a good framework of thinking about it. When you have your early teens, right, they're much more, from this perspective of just concrete thinking, they're much more self-centered, and they're pretty insecure about the physical changes in their bodies because a lot of them are still actively going through puberty and changing, right? And so when you're thinking about their sexual development, again, these younger patients are much less likely to be sexually active. And they're also kind of grappling with their changing bodies, which is an important factor to consider, is that, we're not just going to be thinking about sexual health, we're thinking about kind of physical development as well, and obviously emotional development. In this middle adolescence, they're starting to understand long-term consequences more. And so when you're thinking about sexual health and you're thinking about PrEP adherence, they can start to think through these long-term consequences, but before then it's a lot harder. They're much more concrete. This is also a really important age because they're getting all their information from their friends and also, through social media and the internet. And so this is a really crucial place where us as providers, we need to have these really important and sensitive conversations with young people because they're not necessarily getting their information from reliable sources. And when we think about, specifically young MSM, right, chances are they don't have a huge network of other young MSM that they're asking these questions that they can get valid information from. And so I think that the more that we can train providers to have conversations about sexual health, the better. And it's a really hard thing. And a lot of us haven't been trained for it. And a lot of providers aren't necessarily interested in it. But I think this is just important to think about the overall kind of framework that PrEP and sexual health fall into from a youth perspective. And then when you get to, 18-year-olds, they're thinking a little bit more globally and understanding things in a little bit more of a complex way. And so, your general counseling can be more like an adult, but it still is pretty different from a variety of reasons, anywhere from, confidentiality concerns to just lack of sexual experience. Next slide, please. So a few just considerations with sexual health counseling for adolescents and young adults. Again, this is not new information for anybody, but it's just really worth highlighting. Young people are not comfortable asking providers about sexual health, right? Like it's in a patient visit, they have to get to know you pretty well. It's rare that the first time I meet with a patient, they'll be that forthcoming in terms of discussing their concerns about, sex and their bodies. And on the other side too, is that it's this kind of like self-perpetuating cycle, right? So like a lot of providers are mainly focused, at the end of a 30-minute visit, if you're lucky, a 30-minute visit, right? Of just, oh, by the way, like, are you using condoms? Try not to get an STI, try not to get HIV. There's not really a lot of space to be thinking in terms of like, how is this person developing into their sexual life? And again, some providers are better at it compared to others. And it's important to also remember that patients are often working through their own physical insecurities and also logistics, right? So especially, young MSM who are starting to have, receptive anal sex, there's a lot of questions that come along that they're really, scared to ask that will take a while to come out, and they really can use a provider's guidance on. And when you talk to, youth, they're really getting their information from a variety of sources, right? But a lot of it's just Googling, TikTok, social media. They're not really asking anybody and not really having those conversations as much. These are data that most people are familiar with. This is just looking at the age distribution of new HIV diagnoses separated by age within the United States in 2017. And the only reason why I put it in is I think that when we're thinking about the role of pediatric and adolescent providers, we are really seeing these 15 to 19-year-olds and these 20 to 24-year-olds, they'll transition out of a pediatrician's care around 18 to 21. And we also know that they're not necessarily seeing another provider. So in whatever your kind of provider training efforts are, it's really important to think about pediatrician and adolescent provider outreach, because that's when the providers and patients are having these conversations. And often they're not linking back with a provider until, they're like early mid-30s. Young women are a little bit more likely to obviously see their gynecologist for routine kind of general health stuff, but especially these young men, it really falls off as soon as we stop seeing them for these annual physicals. And when we think of barriers, right, we can kind of think of them from the patient and the provider perspective. So we talked about from the patient perspective, just disclosing sexual behavior. As everybody knows, confidentiality concerns are huge. Adolescents are not going to tell you any confidential information unless they're sure that you're going to keep it confidential. And the other part that I would add to that is that what's cool about leveraging our telehealth and telemedicine capabilities is that it really gives us an opportunity to have these confidential conversations outside of a clinic visit. And so I think that that's been a huge value add in terms of adolescent sexual health and young adult sexual health that way, is that you're not having them wait in the exam room for an extra 20, 30 minutes while their parents or guardians are out there kind of like twiddling their thumbs and wondering what you're talking about. Another huge advantage to virtual care is that there's obviously challenges with frequent follow-up, especially with transportation concerns. And so virtual care is able to mitigate that a bit. We also, through virtual care solutions, we know adherence is challenging for anybody, especially for young people, but there's a lot of ways once we integrate them within one of these virtual health systems that we're able to nudge them a little bit more in terms of adherence. And from a provider, I would just say that, there's variability among providers. Most young people are seeing a pediatrician, and as a pediatrician, 50% of your visits are patients 2 years and younger, right? So adolescents are usually, some pediatricians love working with them, but often it's like out of their comfort zone a little bit. And most pediatricians, not all, are kind of eager to nudge them into adult care as soon as they get to 18. And so there's a real opportunity for provider capacity building assistance, but then also systems that can easily tell these pediatricians, hey, this is PrEP. We know that you may not prescribe it, more than maybe once a year, so you may not feel comfortable. So like, let's figure out how to train you. And here's this great instant telehealth resource that we have that can help link your patients. So a little bit about how our virtual PrEP program helps to mitigate these barriers. So we have 3 components. We have our youth-focused virtual referral clinic, provider education, and community outreach. So with our virtual clinic, so we have staff that are purely Stanford pediatricians and adolescent health providers. When a patient's referred to our program, they're set up with this PrEP doc, and they have all of their follow-up visits there. And this is really huge in terms of making meaningful conversation about somebody's sexual health, right? They're definitely going to tell you more as they get to know you. And this relationship is what allows them to actually listen to you. So this is, I think when you're thinking about youth, it's very different compared to like, you know, a 30-year-old, 40-year-old sexually active person who kind of is a little bit more set in their sexual ways, most likely, and maybe is less receptive to kind of individual counseling. And you need to build that relationship with a consistent provider over time. There's just no way around that. The other thing that I would say is that the virtual manner of these visits makes that really interesting. Like I've personally found that that rapport can be a little awkward to set up, especially during that first visit. And it just honestly, it takes time and it takes experience of just practicing this over and over again, but just realizing that any patient obviously that comes to a clinic is going to be hesitant, right? But that virtual care, it's more comfortable in some ways, but it's also harder to build that rapport to allow for that meaningful kind of counseling to happen. Our visits are free and they're confidential. And what's neat is that, you know, we can practice within the state of California. And so like as our patients go to college or, you know, or anyway, going anywhere they want around the state, we're able to follow them. And then also we're able to accept patients from anywhere within the state of California. So as we've recently launched this clinic for external patients, we're seeing them come from these higher need areas within the state, which is really fantastic. One thing that we provide, like most PrEP programs, is we have a PrEP navigator team coupled with this secure messaging platform that we use within the EHR. And then what's nice about youth, right? We think that more frequent visits is helpful to promote adherence, and we're able to do that really easily through this virtual setting. So again, I think that framing this as a real value add for PrEP in terms of our virtual kind of capacity and seeing COVID as a really important catalyst that's getting us towards better PrEP care, especially for young people. I'll go through a few more of the tools that we've developed, but just know that we do provider training webinars. We also developed a best practice advisory, which I'm going to briefly talk about. And then we're partnering with kind of local schools as well. Again, thinking more through the lens of general sexual health counseling as like a general health, sexual health toolkit, and less about specifically just talking about PrEP. Next slide, please. So our PrEP navigators, we actually work with a group of medical students and PA students. And then we have this dynamic provider pool. And so how we've structured our program, it can be easily adapted to other academic medical centers and potentially community health centers as you start to develop your like virtual care capacity. And the build behind this is a little bit more complicated. I'm happy to talk more offline about it. But what's nice is that once we've set up this program, we can add providers pretty dynamically through this provider pool. And by working with medical students and PA students, it's given us a pool of really eager students who love having this opportunity to get to talk with patients and really build these relationships and kind of practice their panel management over time. And so that's been another really positive thing. Next slide, please. We'll just skip over the scheduling workflow in the interest of time, but feel free to reach out if you want to learn more about that. These next few slides I'll kind of skim through, but just know that part of our system within Stanford, so again, within any kind of medical system that you have, we think about trying to like make this as easy as possible for providers. And so one of those has been a standardized order set. Next slide. Another thing that we did that was pretty cool is we have created this best practice advisory that allows providers in that moment of ordering HIV test to actually learn about PrEP. And this doesn't have to happen in the moment. They can basically click this button and say, hey, I want to learn more about PrEP. Can you send this to me and I'll review this when I have time? And so this is just a picture of what that would look like in a provider's in-basket. And this has been really well received, and I'll show you some data in a few slides on this. Next slide, please. Like I mentioned, we set up a referral system. Those are both internally and externally. And this does take a little bit of build, but it's very doable. What we've done is set it up so that whoever's putting in the referral just has to include a confidential email and a confidential phone number so that it's tracked through our referral system. And again, this allows us to be able to link patients in pretty quickly and to generate a report so that we're staying on top of these and nobody's falling through the cracks. Next slide, please. So this is the part that I really wanted to talk about. So with adults, there's a lot of routine HIV testing. And in adolescents, ideally there would be, but there's not. I think it's something that's like 10% of adolescents have stated that they were tested. And that number is going to be highly variable. And the reason why is we don't routinely do labs on kids and adolescents. And so it's an additional lab draw. And so for youth providers, when they order an HIV test, it's much more risk-based. And so what we did, within our Stanford system for patients 25 and younger, is that we added this hard stop within the HIV test. And this wouldn't necessarily work in adults, again, because there's more routine testing. But we insert a very brief educational tool that says, hey, would this patient benefit from PrEP, a safe daily pill to reduce HIV risk by about 99%? And then they have to select yes, no, they're not sure, or they're already on PrEP. A few great stories that have come up from this. I have one patient who's a heart transplant patient whose providers knew that he was having sex with other young men and didn't really know anything about sexual health necessarily, but knew to order the HIV test. And after ordering it, they saw this prompt, they learned about it, they immediately referred him to our program, and we started him on PrEP within like a week or two. They didn't have to do anything. The referral just flowed straight to us. Another really great example of this is we had a 19-year-old patient who presented to his pulmonologist with secondary syphilis. And again, that provider was like, oh, this is unusual. This patient likely has syphilis. Let me send an RPR. While I'm sending the RPR, I should send an HIV. And as soon as she saw this HIV test pop up, she thought she'd never heard about PrEP before, and she was able to refer him directly to us as well. So a lot of really cool success stories from the youth perspective of ways that we can provide this just-in-time education for providers. All right, next slide, please. And just from the BPA, we're able to launch either the smart set, the provider education, or the referral. Next slide, please. And this is just an example of what the BPA looks like. Another thing that we did is we wanted to make an educational, we wanted to make this as educational as possible. And as you know, there's a lot of confusion in terms of like, when do we start PEP versus PrEP? And so we wanted to include that in just our best practice advisory. And so it reminds providers to really be thinking about recent HIV exposure in that, and then makes it very easy to select any of our options through our BPA. So these are some initial data, I think these are back in like August, of basically looking at what are the providers doing with this best practice advisory. And what's really astounding is that around 40 to 50% of providers are selecting to receive that in-basket message. And so that's something that's completely optional. We're not mandating that providers receive it. They're saying that they actually do want to learn about it. And so that's a huge marker for success. And again, it's just another way to think about how we can, train providers in the moment. Next slide, please. And this is just from some of our early referrals, just showing we see like the concentration of HIV diagnoses within the state, and then we're seeing where our patients are coming from. And so through a lot of our online advertising efforts, we've been able to tap into some areas that have a higher burden of HIV diagnosis, which again is a really positive thing that we've been able to do. Next slide. So the takeaway messages, so we know that youth account for a significant percentage of HIV diagnoses, but beyond thinking of this in like a purely 15 to 24-year-old kind of issue, we think of it as like, how do you give the message to pediatricians and adolescent providers at the time when they're having these conversations before young people kind of fall out of this routine care? And just a reminder that, young people are really developing their sexual lives. Maybe they've had sex once, maybe they haven't had sex at all yet. And so when you're thinking about counseling, it always needs to be more than PrEP, and you need to really be framing this differently for young people. There's a lot of knowledge gaps for providers. And so, our just-in-time BPA tool is one tool that we've used, we found was really helpful. I think the other thing is this referral to a specialized PrEP provider, because at the end of the day, youth providers don't usually prescribe Truvada. It's a huge practice shift, and they may not be doing it that often. And so I would much rather focus energy on training providers to recognize patients that could benefit from PrEP and refer it. And then those that do want to be trained, of course, we can train them, but the majority are probably going to want to refer it to somebody else, just given the limited number of patients that they would see. And then finally, really thinking of this as a virtual care model and how it can be used to mitigate a lot of these PrEP barriers, especially for youth. And really thinking about, the different initiatives that your organizations are doing to try to get patients out of the clinic, basically, and do more of this from home, and saying, how can we jump on that ship and say, hey, let's use all these tools that we're developing for PrEP. So for example, Stanford is now working on developing at-home testing kits, and we've been talking about at-home testing kits for PrEP. Suddenly there's a huge interest, once they've developed this infrastructure, right? How can we use this in a more sustainable way once, hopefully COVID passes? And so really seeing PrEP care as a way to sustain some of these telehealth initial investments over time. All right.
Great.
That's
Thank
it. I
you,
included
Jeff.
my questions for the group too, in case you needed those, but I think I'm probably already over time.
No worries. Thank you very much. And there's one question, I think, in the chat that you haven't answered through the info in your presentation from California. Do you have a system to avoid this is not a bill that their parents and guardians may see?
Yeah, so this is going to vary depending on the state. And so the specifics in California, right? So you can have them enroll in the Family Pact program, which allows them to have access to paying for the lab, for most of the labs, and then also for the visits, but not necessarily the medication. For patients who are uninsured or on Medi-Cal, that's usually less of an issue. For the privately insured patients, it's usually a bigger issue. And so there's various kind of drug assistance programs that you can do to actually pay for PrEP. So we usually do a combination of those two. But I would just recommend that you're clear about whatever those are for your state. There's a website, myhealthmyinfo.org, where patients can actually go in and request that it blocks the explanation of benefits, which is only going to be an issue for patients 17 and younger, right? Because if you're 18, your parents shouldn't be able to access your medical record. The issue, though, right, is if you have a really, any parent who's just watching their deductible dwindle away, they're going to be like, what are you spending $2,000 a month on, right? I think that this is an issue that there's a lot of concern about, but in practice, it doesn't come up as often, or at least I haven't seen it come up as often. And so I think it's an important barrier to consider, and you need to have a plan, but it shouldn't slow your rollout in terms of trying to expand PrEP services to youth, because you're almost always able to figure out a way around it. It's rare when I've had a patient that's like, I cannot have my parents find out about the deductible, nothing. And in those cases, when that does come up, just remember you always have, Planned Parenthood as your ultimate backup, but hopefully different services through kind of local kind of city, county, and state health departments as well.
Great, thank you. So folks, for everyone on the line, now's the time we're going to start talking about some of our local programs and initiatives that you might be doing in your sites, and open it up as well to general questions. If you're able to, this would be a good time to turn on your camera. If you're able and willing, no pressure, but this would be a good time to just see everyone and be able to interact with each other if you can. And I just wanted to mention the special guest we have on our West Region call today, all the way out from the East Coast in DC, Mr. Edwin Corbin Gutierrez, and from NASTAD. And NASTAD is running a national learning community specifically on telemedicine. So Edwin, I don't know if you wanted to just say a few words about the national collaborative. And I know that some of our West Region health departments, including some that are on the call, are part of that NASTAD effort. So we'd love to hear what your national collaborative is working on, and maybe some examples of some beginning work that folks are doing in the West.
Sure, thank you. Thank you, Gary. Hi, everyone. So I'll be brief. We are in session 3 is happening right now. So my colleague Nicole is leading that, and I think we're gathering models from across the country that are replicable. Some of the kind of areas of interest have been around incorporating pharmacists into newer roles, including providing prep and referring clients to a provider, but also working on collaborative practice agreements. We are working a lot on integrating self-testing. So I think a lot of the topics and kind of best practices that were just covered, we are going to be working on 340B and sustainability quite a bit. And throughout this process, this is a 6-month endeavor that we're asking health departments to and their providers to join us for. And we will. This is the first cohort. We will be sure to share promising practices and resources that come out of this work. So stay tuned. And yeah, we'll share those through this group. Thanks.
Great. And are there, so for everyone on the call, are there jurisdictions, we'd love to hear jurisdictions that maybe have started some telemedicine efforts, just so we can hear a little bit about your successes and challenges. Maybe there are some folks who are at the very beginning of trying to develop workflows and processes, or maybe some of you who have encountered initial barriers and have gotten stuck. We would love to hear some experiences. So please feel free to jump in and just identify yourself when you do so we know where you're from.
Hi, I'm Kevin Sitter from the California State Office of AIDS. And since our inception, we've had a contract with a telehealth service. It's been used minimally and not as much in our rural or our areas that don't have PrEP providers. It's been used more by people in urban areas, but the convenience of the telehealth versus the physician has been preference. So not much uptake, but it's there guaranteed to be available to anyone in the state. Our intention was to reach rural, but it's being used more by urban.
Kevin, this is Jonathan Fuchs. Thank you so much for sharing that. I was curious, and appropriately so, like trying to target this for rural settings for the convenience of it. And I was curious, what kind of feedback have you received in terms of barriers for rural settings to be able to take this up?
I think the barrier is that we haven't even gotten feedback because we don't reach the rural areas successfully or well. That we need to do better at marketing into rural areas. We need to be hooking up to services they are already receiving closer to home to share this information. But to date, I don't think we successfully reached out to rural gay men or rural consumers that are PrEP eligible.
Thank you.
Others? Or others who would like to begin telemedicine efforts that are having any challenges? So I think a few of the jurisdictions had said, Denver, you all are both a SEBA provider and a jurisdiction. Do you want to talk, any of the staff from there want to chat about some of the work that you've been doing?
So Gary, when you said in terms of a lot of the stuff that we are doing regarding telehealth is a result of, as Karen talked about, the challenges due to COVID. So we've had aspects of our team working to do linkage via using virtual technologies, using phone banks. We just understand that a lot of organizations spent April and May learning a lot about telehealth because there was a telehealth webinar every day. I think Bev Wasserman and I were just counting in April and May. I think there were just so many telehealth webinars that we were trying to attend because we anticipated that people would be really clamoring to use this resource. And there are a lot of different ways to use telehealth and a lot of different information out there. We believe that that resource that Karen shared in the chat during her presentation is a great way for people to start. We would really, it's only 15 pages, so it's not a heavy read. You can read it while having your morning cup of coffee, but there are some pages there that I think are really important. I mentioned before page 11, give that a visual gander. It is just a really great resource. It tells you all about telehealth programs and what you need to do to start. Finally, I will say this, we are excited to provide technical assistance to organizations who want to do telehealth. Put in a CTS request, and we have experts who are just willing to help with that. So Karen, is there anything else you would like to add to that?
I think you pretty much covered it. It's so interesting to hear the barriers that you're having out in rural areas. I know that some of our colleagues in Mississippi have really leveraged DIS, who are hearing about people with new diagnoses of syphilis, new diagnoses of GC or whatnot, to kind of bring that service to them, to suggest the service. But like you said, I think it's going to take a lot of thought about how to get the message out there. For us, we had a client base that was already very invested in our clinic, who we were already converting into this model. And so I think you bring up a great question of how we can really leverage this innovation to bring PrEP to people who haven't had an opportunity before.
Thank you.
And I'm sorry, Gary, I just want to say, Kevin, you bring up a very good point. I'm reading your comment in the chat. We have encountered many organizations who are trying to move a lot of their services from in-person to virtual. And one of the biggest barriers are one of the populations that they would like to have these services in are services that are on the other side of the digital divide, meaning that they have little access to the technologies that we so readily enjoy. So I think a lot of that is figuring out how to minimize this barrier, to think about other ways that we could help the clients who are really the most vulnerable if they are using phones that don't have access to the internet, or they have phones that can provide them with little time on the internet. So those are very real challenges that exist in both urban settings and suburban and urban and rural settings. I think that is a reality for many people.
I agree, Ty. One of the things I appreciate is how many people were using the public libraries as their access to the internet. And combination of the public library shutdown and the intimacy of a lot of the webinars or Zoom meetings that we have with clients, that's not an appropriate place to do it. So you're correct. Not only do we need Obama phones, but we need telephone plans that allow them the success at joining multiple meetings throughout the month.
Mm-hmm. Excellent point. I'm going to call on our friends in Nevada. How are things going there? Have you utilized telemedicine? Are you looking to implement more? Are you looking to start up something? And what are some of the, if you are, what are some of the challenges you might anticipate?
Hello, Gary. This is Preston from the state of Nevada. We have one of our providers offering telemedicine here in Southern Nevada. However, we've been having challenges with, I would say, the uptake of offering telemedicine. I think a lot of providers are nervous with the technology portion. Some facility has it, some facility does not have it. Liability of Zoom. Do we use WebEx, certain different platforms, so on and so forth. So of course, we're requesting TA to get assistance regarding that for that. I don't know about Southern Nevada. Sabra, can you answer more about that?
Oh,
I believe, so this is Sabra with Southern Nevada Health District. I believe at this point, our sexual health clinic is looking into starting a telehealth program. Many of our providers have been speaking with our clients through telephone visits, but as far as like a telehealth actual program, I don't think we have started that just yet.
Okay. Thank you. How are things going in Riverside County? Do we still have Riverside on the call, Jane?
Hey, I'm sorry.
No worries.
I just, we just need some support in getting to the young people. And I don't know, because this is something we've been doing in prevention since I started 8 years ago. We just need to get to the young people who are on Grindr. And we're finding that more than 50% of our new cases are of HIV positives are from Grindr. And so it hurts my heart when we can't reach these people before something happens. So any help or suggestion or technical assistance would be awesome. And I think Grindr could do more. I don't know, but it's a huge stumbling block for us.
Jeff, is Stanford Children's doing any advertising on the apps targeted specifically at young people to help them engage or be aware of teleprep? And is that something that a local jurisdiction might be able to partner with you all to do some targeted ads in their jurisdiction since the Stanford program is open statewide?
Yeah, I think it's a great question, and it's been a challenge for us too. So as you can imagine, a children's hospital maybe is not the most enthusiastic about advertising on Scruff and Grindr. So we're working on kind of bringing this under the Stanford Medicine umbrella, right? So we're getting there. We do ads, we do AdWords on Google, we do Facebook and Instagram. And the focus of a social media campaign is obviously different than AdWords, right? You're trying to kind of increase awareness overall. I would love to start doing ads on Grindr, and I'm hopeful that that's the next step. I would say for anybody within California, like, I would love to partner with anybody who's interested, because we've set up this infrastructure. We have our pediatrician adolescent provider team. I see Kevin waving, I like it. But I mean, like, we've done the legwork, right? And like, all we need to do is get the word out, right? And then we're making it so that, like, as soon as they know they want to make an appointment, we're working on online scheduling now. So they can say, oh, great. They check my schedule, and let's say like 4 p.m., tomorrow I have an opening in primary care. Like, I can see that patient the next day, right? So it's, we feel free to reach out to me. I think you have my email, and Gary can pass that along as well. But I 100% agree that we need to get more into these apps, right? Take what we've learned. And so what's good is we've done a lot of kind of testing of our various ads and images through Google and Instagram and Facebook, and we have a good understanding of what are the ones that are the catchiest. And now we're just working on expanding these to more of the dating app space. So let's connect and let's figure out a way to do it.
Right. And one last thing, we did have at one point some ads on Grindr, but I think it was like a 30-day kind of thing. this has to be out there all the time, because it's just, 30 days and gone is not really a big help. But if people see things over and over and over, it's like, break me off a piece of that Kit Kat bar, you just start thinking about that, whatever it is, because it's in your head. It's that earworm that's in, it's something that we just really, I think, have a big opportunity to make better and make more efficient.
I'd like to share a resource for everyone on the phone. Dan Wolfeiler and Jen Scheck at San Francisco AIDS Foundation have an organization called Building Healthy Online Communities. And they have built a rapport with Scruff and Grindr and all the different dating apps. They're currently doing a pilot within the 6 phase 1 jurisdictions, maybe the 8 in California, of sending home test kits to anyone who requests one with some criteria and some follow-up if the people engage with them after the test. And so Dan Wolfeiler, Jen Heck are the perfect people to reach out to gain access to the different gay men's dating apps.
Okay.
And Kevin, great segue, because Jen and the Building Healthy Online Communities program is going to be our presenter for the December Learning Community right here on this channel. So not only can you reach out to Jen and her group, but Jen's coming to you. And for everybody that's going to be on the December call. So we're very excited, and nice to see that there are so many concrete links between the topics that we've been doing. Just wanted to, before we jump into wrap up, just wanted to ask one more jurisdiction. Let's see, maybe New Mexico. How are you guys doing, John? Or are you thinking of starting? And is IHS in your state doing telemedicine efforts with the tribal nations as well? But also, how is your health department thinking about telemedicine, or have you done some?
We've done a little bit. What we call our Project Spicy, which is a bunch of nurse practitioners that we have hired on contract to specifically do PrEP and syphilis. In our state, they have been using telemedicine more frequently, especially our provider out of Las Cruces. She's been amazing. She's got like 60 clients, I think, right now that she's serving with on PrEP and tracking, and she's using telemedicine basically for most of it. They come in, they'll quickly do the Insti test to get the HIV test and the blood draw for the labs, and then the rest of the visit is all done basically while they're in the parking lot and she's inside, and they just do the rest of the visit through Zoom or whatever's available, FaceTime or so forth.
Great.
But that's that's basically all I think that's going on right now. Everything else, all our Department of Health has been shifted toward COVID testing and so forth. So we still, there's still walk-ins for STD treatments, but beyond that, it's all COVID. That's all it is. That's everything.
And I think, one of the things we're looking at as SIBA providers is, how to integrate HIV, HCV, and STI testing with COVID. So is there some integration that can be done maybe at COVID testing sites using mobile testing vans that community-based organizations might want to get running again? Is there some home testing that folks can do? Can you ask someone at a COVID testing site if they're interested in additional testing and hand them, a home testing kit before they leave? So I think everyone is brainstorming right now creative ideas to deal with the reality that COVID testing is, the strongest presence out there, and how can we really leverage that opportunity? So thank you. And a few great comments in the chat. that I won't repeat, but just call your attention to looking at as we wrap up. I just want to say thank you to our phenomenal presenters today, Karen Wendell and Jeff Hart Cooper. You all are amazing. And it's great to hear about some of the successes locally in your jurisdictions, as well as some of the potential challenges and the interest in TA. Two things I want to leave, or three things I want to leave you with. One, just a reminder again that Jen Hecht and the Building Healthy Online Communities and the topic of home testing will be the focus of our December call. So keep on the lookout for reminders about that, and join us at the same time and place in December. Secondly, we encourage you to really make sure that your accounts are set up on the group site for the West Region Learning Community, but a positive update about the community. Some things are expanding like crazy in the online community. So definitely becoming an important place to be checking into regularly. We have brought in all of the participants from the detailing learning community, so you'll see them in there. We are potentially looking at other initiatives within the West in these high impact HIV prevention efforts to be joining. We may be joined in the future by PrEP navigators and other groups. So that is going to become the one-stop shop for regular communication on an ongoing basis in between these calls, or if we start focused sprints on particular topics that your health department may or may not participate in, it's a way to stay in touch no matter what's going on. And I just want to remind everyone, our kickoff for this learning community this fall has been amazing. We're already in into multiple sessions and have another remaining in this initial sprint in December. Then we're going to reassess and talk about what you all want to focus on moving forward. And we have a couple of options. You know, this fall, we've been kind of peppering you with a couple of different topics based on some of your immediate needs that you identified. So you all identified the topics of telemedicine and home testing, et cetera, as your focus. Workforce development, shifting to virtual, those were all some of the initial priorities and topics that you thought would be helpful to cover. So we've done this initial sprint through the end of the year with different topical focuses each month. Another option is that we pick a topic and we do a sprint on a singular topic for a few months to really get a little more deeper into it. So for example, in the spring, if folks decide telemedicine, teleprep, or home testing, or whatever the topic might be, and you want to do 3 or 4 sessions on that, we can go much more deeper into a particular topic. So as the CEBA providers, we will start to assess as we approach our next December session, and after that, before everyone is away for the holidays, kind of where your interests are in going for the spring. We can even break out into multiple topics. If half of our health departments are interested in, starting a telemedicine program, but the other half is interested in focusing on home testing or some type of structural intervention or racial equity, we can even break out into 2 groups that run in parallel. So keep letting us know what your priorities and interests are, and keep looking out as we continue to assess what that is. But I wanted to say a final thank you to everyone for joining today. Thank you, as always, for the local jurisdictions for sharing your experiences. And we look forward to seeing you all in December. So have a wonderful, safe, and healthy, COVID-free Thanksgiving.